in this All India Ophthalmic Symposium.
Oh, okay, great. Thank you. Thank you for the very interesting talk. I think I'll hand over to you for the next segment.
Yeah, the next speaker is Professor Rajesh Sinha. So the backup team, do you have any video or Rajesh sir is here? I think he is not there. We'll go ahead with the next presentation. Next presentation is Dr. Harbans Lal. Sir is here. Sir, can you hear me? Dr. Harbans Lal? Okay, he might be busy with some of his work. So I'm the next speaker. I'll present my slides. Is my slide visible? Dr. Wang, is my slide visible?
Yes.
Yeah, thank you. Good evening, everyone. So I'll be presenting on surgical training in wet lab. So the ophthalmic training consists of theoretical teaching as well as surgical training, and the surgical training initially begins in the wet labs. So here we are going to teach the basic steps to the residents and the trainees, and then we are going to demonstrate the surgeries in real actual OT rooms. Then we are going to give the cases. So at our National Eye Center in RP Center, AIIMS, New Delhi, we have virtual simulators as well as we train on animal eyes. So this is an IC simulator for cataract, which is basically used. So it's like a video game. Majority of the residents are going to learn how to do the continuous curvilinear capsular axis. Also, they are going to learn how to chop the nucleus and how to use the phacoemulsification for cataract surgery, because cataract surgery is one of the most commonly performed surgeries, and every residency training begins with cataract surgery. But as far as like artificial modules are concerned, they are very unrealistic, and they are going to give a sort of video game sort of feeling. The real tissue interaction, the hand and memory, this thing. So that is not imparted by the video games or the IC simulator. That is a major drawback. We are not going to touch the real cornea. We are not going to feel the vitreous loss. The lens nucleus is not going to be as real as human eyes. So we have close neighbors, that is animal eyes, which are like quite similar to human eyes, but they have different tissue elasticity and other features. But they are going to be a very close this thing. So here I'm going to tell some of the things which we followed our National Eye Center. So whenever we bring animal eyes, specifically we bring more of a goat eyes. So they are going to cost 4 pieces for $1. We are going to inspect the globe, whether globe is intact or not, and whether it's having any sort of injury. So the one which are not having an injury, we are going to inspect them. We are going to identify the landmarks, including the big equator and the limbus. Once the intraocular tension is quite, negotiables, then we are going to wrap the globes. So this is how we are going to wrap for like corneal surgeries, iris surgeries, and the cataract surgeries. So here around 2 or 3 millimeters of the antisclera is visible along the cornea. And this is a cross-sectional view, which shows that how to wrap the globe using a gauze face for anti-segment surgeries. So similarly for glaucoma surgeries, we are going to slant because we are interested more in the limbus, sclera, as well as some part of the cornea. So by tilting the globe forward, we are going to wrap the globe. We want to have the exposure of the sclera as well as the limbus. So this is how we are going to wrap for the glaucoma surgeries. After that, for squint surgeries, we are going to identify the extraocular muscles, which are having sufficient length up to 10 to 15 millimeter. And the one recti which is having very close resemblance with the human insertion. So we are going to identify that rectus and we are going to wrap along the cornea. So this is how we are going to wrap the globe so that the muscle should be at the apical region. So after this one, we are going to mount these eyes on the mannequin heads, corneal, and the cataract surgeries. This is how we are going to mount, and we are going to rotate the cornea. So depending on the superior or the temporal surgeon's preference, we are going to rotate the clear portion in that direction, and we are going to teach the surgery. For glaucoma, as I previously said, after wrapping, we are going to tilt the globe anteriorly so that the limbus, sclera, as well as some part of the peripheral cornea is quite clearly visible. For squint surgeries, we are going to put the wrapped globe inside that mannequin head orbit. And after that, we are going to suture the free end of the muscle so that just to simulate the resting tension within the muscle, we are going to attach this one to the neighboring strand. So for cataract surgery is concerned, there are so many modules which are being used. So in our setup, we use, apart from IC simulator, we have a goat size, which we bring at least 20 to 25 pieces per day. We have a residency strength of 150. So here, after bringing the goat eyes, which are qualifying our criteria, we are going to keep these eyes in oven, so for 5 to 6 seconds. So that's how the nucleus becomes hardened. And on the left side, you can see we are teaching the small incision cataract surgery. On the right side, you can see we are teaching them phacoemulsification. So in addition, we are going to teach them how to put the IOL in the bag, in the sulcus. On the left side, you can see the IOL has been placed in the antechamber. So in the middle diagram, you can see that some residents who are dedicated refractive surgeons as well as IOL surgeons, they want to simulate the SFL surgery. Here, we are going to use additional multi-piece haptic to join the original multi-piece IOL, so that because the corneal diameter, the least diameter is around 15 millimeter in the goat eye. So after this one, we are going to increase the length of the haptic, and we are going to make side pockets, how to stuck the haptics in the scleral pockets, and that's how we are going to give an orientation regarding how to do SFL surgery. On the right side, you can see that we are going to get an example of square-edged IOL, and that's how we are going to simulate the ICL surgery, how to lead the, how to tuck the leading haptic and the rear haptic. So in addition, we have systematic protocols where using Oscar's scoring system, we are going to grade all these surgeries. So we begin from simplest surgery to the complex surgeries. So this is corneal tattooing. So by epithelial debriding as well as by making a corneal pocket, we teach them how to stain the corneal stroma. And this is induction of the corneoscleral perforation. We take a good looking eye and we induce a clear corneoscleral perforation, as well as in advanced training programs, we are going to induce ragged or irregular corneal wounds and the scleral wounds. How to do vitrectomy, how to secure the antechamber, how to secure the limbus, and how to suture the corneal as well as the scleral wounds. This is how we are going to teach them systematically. In addition, for the beginners who want to enjoy the congenital suturing or the congenital dissection, we offer them the congenital or the pterygium grafting technique as well. So in addition, the residents who are going to be posted in the National Eye Bank, who are going to assist in eye retrieval or the cornea scleral button retrieval, we demonstrate them how the systematic retrieval is done. So after that, orientation only, they are going to give them few hands-on experience in wet lab. Then they are allowed to accompany the surgeon who is going to retrieve the eyes. In addition, for like people who are going to do keratoplasty, we have different set of triphyans as well as keratoplasty instruments where they are going to look for clear corneas after debriding the epithelium. We are going to define the central portion, and we are going to teach them how to maintain the antechamber so that you can place all the sutures, and the sutures are going to be well trained. So in addition, we are going to teach them how to do the lamellar dissection of the anterior cornea so that we can take out all the anterior corneal tissue layer by layer using the blade as well as scissors. Then we are going to teach them how to suture the anterior corneal graft. So in addition, DMEC is a bit difficult in goat eyes, but we are going to teach them, we routinely teach them how to peel the endothelial structure so that they can get a practical or like theoretical, at least theoretical understanding regarding how the tissues are used. As far as glaucoma is concerned, so I have prepared this module. This is published in Journal of Glaucoma. After doing keratoplasty, we just discard the corneoscleral rim after giving some portion to the culture. But we are going to use this one. On the left side, you can see that the yellow asterisk shows the triphined end of the cornea, and the red asterisk shows the pigmented meshwork, trabecular meshwork, and the blue arrow shows the scleral spur, and the white arrow shows the iris insertion. So beyond that one is our ciliary body, which was there initially. So I take these tissues to the wet lab, and I just hang in front of the slit lamp. You can see here, and I'll try to teach the resident how to do a slit examination as well as diffuse examination, so that they can get an understanding how exactly the angle looks before imagining how the gonioscopy is done. On the left side diagram, you can see that in addition, we can use this corneoscleral rim. You can see that this corneoscleral rim we are visualizing. After that, we are going to define the central portion. So once we are able to define that one, we are going to use a corneoscleral rim which has trabecular meshwork. So we are going to implant this on a clear cornea. This is artificial cornea. You can see the rim is implanted. After that, we are going to transplant this onto a artificial chamber, right? So whatever the air is there in the antechamber, we are going to replace using fluid through an inlet. And this module is now prepared or ready for gonioscopy examination. So this is indirect gonioscopy. You can see after coupling the gonioscopy onto the cornea, you can see we can visualize the angle structures here. So in addition, the residents can also do, or they can also perform MVR assisted goniotomy. This is another example where the mounted apparatus, we are going to transport that onto a slit lamp. In front of a slit lamp, we are going to hold, fix the artificial chamber. Through that one, we are going to teach them indirect gonioscopy also. So this is goniotomy. So in addition, so what are the newer trends are there? Micro-invasive surgeries. So as far as India is concerned, we have only trabecular bypass stent. So in wet lab, we have dummy pieces where we are going to inject them into the trabecular meshwork. We will teach them this is how the stent looks like. This is how it is injected. In addition, we have subconjunctival as well as suprachoroidal stents, but we don't have. So, but we are going to use smaller needles, which we are going to introduce through the trabecular meshwork to the respective spaces so that they get a orientation. So in addition, we routinely train, and we have a module for this one also. We score all the senior residents before giving any human eyes. We teach them at least 10 times trabeculectomy on both sides. In addition, releasable sutures on this thing. So this is for just for like practical understanding. Only senior people will do the AGV, but the residents, they are interested. When they are interested, we teach them how to put the AGV, how it functions, how the basic things are done. So in addition, some people who wants to repair the iris tear, who wants to practice the pupilloplasty as well as iridodialysis repair. So using a suture, so how to do a single pass 4 through pupilloplasty or even iridodialysis, we teach them. We simulate them routinely. So as far as vitreoretinal is concerned, there are lesser modules for vitrectomy, but routinely we teach the buckling surgery. Here we are going to take muscles from different eyes, and we are going to suture onto one eye. And after simulating 4 recti, we are going to teach them how to put the buckle as well as encerclage, and how to indent, how to see to indirect ophthalmoscopy, how you are getting the indent, how to tie the final knot. This is we are going to teach. So last but not the least, so strabismus surgery, as I'm a strabismus surgeon, there are various models. You can see this is a chicken which is being placed on the thermocol, but this will not give a real situation regarding how the sclera is. So the resident should make a scleral perforation on the goat eye. Then only he's going to learn what how the sclera is, what is the rigidity of the sclera, how he is going to feel once there is a perforation, and how the vitreous looks like when he has made a perforation. So for that one, these are going to be lesser preferred modalities. On the right side, you can see these are silicone modules. Again, you are not going to have any elastic tissue which resembles like a tenon or the sclera. So for this one, I have made this module where you can see on the left side, on the A diagram, you can see the blue asterisk shows the lateral rectus, the green shows the inferior rectus, and the red shows the inferior oblique muscle. So how to identify the inferior oblique muscle, how to disinsert from the insertion, and this is Fink's procedure. So I'm basically going to tell all the theoretical surgical procedures. So what is a 6 mm behind and 6 mm posterior? That's how we were like Fink's procedure. 2 mm lateral and 3 mm posterior, that is Park's procedure. And just lateral to inferior rectus, this D diagram, that is your like Elliott and Ankin procedure, total anterior positioning, and even the stages of the intranasal transposition. So apart from this, all recti surgeries can also be simulated. On the left side, you can see that is a wire splitting procedure of a recti. On the middle diagram, you can see partial thickness recti are being transposed like it's a partial lamps. On the right side, you can see it's a Farden surgery. On the F diagram, you can see there's a post-equatorial fixation of the globe. So this creates a good memory in front of the residents, so they can learn, and when they are reading the theoretical part, that's going to be very easy. So this is no tenotomy, no dissection, muscle belly transposition, that is Nishida's procedure. So in addition, on the left diagram, you can see that this is superior rectus, the red asterisk and the yellow asterisk shows the supraoblique muscle. So how to hook the supraoblique muscle, how to do tucking. On the right diagram, you can see the most commonly performed surgeries on the supraoblique is posterior tenectomy of the supraoblique. You can see the whole of the supraoblique is being separated, and anterior 2 mm 1/7 of the tendon is separated from the remaining 7/8. So that's how we are going to take a bite from the posterior depressor fibers. So that's how we are going to complete the posterior tenectomy. So on the left side, you can see these are another theoretical hanging lobe tenotomy as well as Harada Ito. So to conclude, in wet lab, a significant number of routine ocular surgeries can be simulated, and to improve the so that we can improve the resident surgical skills. So we often train these in our wet lab. We have these posters. So whatever the resident is interested, we are going to make a group of 4 to 5 people. Then we give them hands-on training. In addition, we have also strabismus surgeries. For all these surgeries, there is a defined ICO score. So whatever score model is there, we have booklets, and we are going to give one sheet for each resident, and we are going to mark them. So once they achieve the required skill, a senior resident or the faculty is going to assess. So once the concerned senior person, says that he has achieved the necessary required skills, and there's a documentation that over a period of time he has improved all of his skills, and he is now able to assist or like do the surgeries on human eye, then only he is allowed to perform the surgery in wet lab. So these are my work pertaining to wet lab training. Thank you.
Thank you, Amar.
Thank you.